Thank you so much, everyone, for joining us this evening for our monthly LEJEndo meeting. My name is Ben Mondelli. I'm a consultant gynecologist in Royal Surrey in Guildford and part of the CIMIG team. With me today, there is Flo Britton, that is the current fellow for Shane Casali, and we're very lucky to be joined today by Mr. Tom Smith-Walker, which is going to enlighten us and going through the updated NICE guideline on endometriosis, the diagnosis and management that came out recently. Mr. Shane Casali is hopefully going to join us soon after the start of this meeting, as is currently stuck in traffic and just finished working. And Mikey Adamczyk is with us with his heart, but is stuck as well in a very busy on call. Then, of course, we have also the rest of our LEJEndo team with Kai Flesher and the rest of the team that, again, unfortunately, weren't able to be with us today. Today with us, we have also Rakesh Singh, that is one of our fellows, that is going to be able to present some of very interesting papers. I want also to thank you, Carl Storz, that is helping us setting up this meeting and support us, and wouldn't be able to really do it so well without them. And this meeting is, of course, done in collaboration with the EEL, the European Endometriosis League. So I think we can start with a couple of very short articles that are going to be presented by Flo and Rakesh, and then we can move on with our feature article. Please feel free to ask any question in the question and answer box. Okay, do you want to start, Flo?
Great.
Thank you.
Oh, sorry, Evening, my name is Flo. Today I'm just going to go over this first paper to begin with, which looks at the long-term gastrointestinal function outcomes in women who have undergone either a segmental bowel resection or a full-thickness discoid resection. This was published just last month in May by Gernot Hüdelist and his colleagues. So the management of deep colorectal disease still remains contentious as to how we manage it surgically, whether you shave, whether you do a disc or segmental. And actually the evidence, is leaning more towards the size of the nodule, where it is, how many there are. But what this paper is actually looking at is it's looking at the long-term gastrointestinal outcomes in these patients, depending on what surgical excision they've had. Now, they have already published the results of this at the 3-year post-operative point, and that was published, and actually Gernot Hüdelist presented already those results in LEJEndo last year. But this is an add-on to that study. It's now looking at those patients at post-operative visit 2, which is at 5 years, and seeing how their gastrointestinal function fares from a functional point of view, measured with their LARS, so lower anterior resection syndrome, but also with their quality of life, so with the GI-QLI. So this was a prospective study. It included patients who either underwent a segmental bowel resection or a full thickness discoid resection for symptomatic colorectal deep disease. And this was carried out in 2 tertiary referral centres based in Vienna. The study included 92 patients with symptomatic disease, and 76 of these had a segmental bowel resection and 16 had a full thickness discoid resection. As I said, the previously published results were at the 3-year mark, but this specific paper looks at visit 2 at the 5-year mark. And the assessment tools they've used, so the LARS score, which is just 5 questions that categorizes a patient into either having minor, major, or no LARS, and then their GI-QLI score, so their quality of life index, and that's a patient questionnaire that generates a score between 0 to 144, with the higher number depicting a better quality of life. So going straight to the results at the 5-year, so you can see here that for the segmental bowel resection shown by the column on the left, patients had a significant long-term improvement in both LARS and in their quality of life, indicating better bowel function, but also an improved quality of life. However, in contrast, if you look at the right for the full thickness disc, whilst they did have a sustained improvement in their quality of life, their LARS scores actually worsened between year 3 and 5, returning to near pre-operative levels. So it suggests that both techniques improve the quality of life, but actually it's the segmentals that offer a more stable long-term functional bowel outcome. And this is just a box and whisker diagram just to depict that. So on the left, the LARS, you can see with the segmental, actually at the 5-year mark, it's returning to that sort of pre-operative level. Whereas with the disc resection, you're still getting a statistical improvement in their scores. And then looking at the quality of life in both surgical approaches, there is a sustained improvement in quality of life over the 3 and the 5-year mark. The study then went on and did a subgroup analysis on patients with pre-existing LARS prior to surgery, so those that had either major or minor symptoms. And it shows here on the graph that actually segmental again shows a clear benefit. So LARS scores are significantly improved and they remain stable, as do the quality of life scores. However, in the disc subgroup, there was no significant long-term improvement in their LARS scores, but there was quality of life. So takeaways from this. Both approaches improve quality of life. Segmental consistently improves bowel function over time and actually may be a better option in those patients with pre-operative symptoms. But I think also the study shows or highlights really how we measure outcomes really matter. So the patient-reported outcome measure. So whilst the LARS suggests their bowel function, it could be argued that actually their quality of life index sort of captures a broader impact on the patient's daily life. So whilst it's important to decide what's the best surgical approach for these patients, it also needs some thought as to how we're measuring their outcomes, because that can be very significant in interpreting these results. And then there were some limitations that the group mentioned or in their paper. So it had 92 patients, so a relatively small number of patients actually had a disc, only 16 compared to the majority that did actually have a segmental. And there was 24% lost follow-up, which, considering the length of the study, 5 years, is actually probably quite good. And actually, this is one of the longest prospective studies looking at this specific area. So it does actually, the results are, give us valuable insight. So really it addresses, with all endometriosis surgery, it's not so much, the challenge isn't always just removing all the disease, but actually having the evidence over a long enough period of time to actually really appreciate what truly helps the patient.
Thank you, Flo. Yeah, it's an interesting study because yeah, it's really something that we need to take into consideration. And I think what is interesting, correct me, Mr. Smith Walker, ask your advice, your opinion as well. It's quite interesting to see how many segmentals were done because it was in 2017 it started the study, if I'm not wrong. And at least what we can see now is that the number of discs that we're doing is almost, if not actually superior to the number of segmental that we're doing, because the number of lesions that are usually less than 3 centimeters and are discable are way more frequent than the one where a full segmental resection is done. Yeah, the other thing we need to look into, like, I don't know if this study is mentioned, is like how low were the lesions while they did a segmental or a disc, which one were the ones that were causing a low anterior resection syndrome, how long was the segment removed. I think there are so many things that needs to be taken into consideration as well. What do you think? Probably Miss Walker is not on yet. But yeah,
Yes, Yes, he is. I
Hi.
can see it.
Sorry,
What do you think?
Hi, Tom.
Hi there, you're right. Yeah, no, I agree. I think that there are a lot of things that are unknown. You also need to know the complication rate from it as well, and you know what the negative outcomes were. But I think it is having that information. You know, I think the number of discs that we've been doing are much less, and more into the segmental resection. I think that's the extent of the disease that dictates it and the symptoms. But I think 5 years data is really useful, and it'd be great to take the data that we've got, the 2-year data from the database, and then extend the UK data, you know, to get that research to do it. And then, you know, we've got large numbers from multi-centers. That would be a interesting thing.
Hello. Well, first of all, that was amazing presentation. Really nicely summarized it. But did they explain what potential explanation they have? Because with the disc, you would expect that you're not doing anything to the nerves, you're not doing anything to the function of the bowel in terms of the capacity, and you're not taking a segment. You would expect that you won't get any Lars reduction with a disc. Did they explain what they think the explanation is?
They hinted at it, but they didn't really unpack it. And I think they did suggest that with disc, you're potentially causing fibrosis at that site, which can impact bowel function. And then also talking about actually just removing. So if you've got, with these patients, they're going to have a degree, all of them of pelvic floor dysfunction. And actually, if you're removing the whole segment of bowel, that might restore more of the function of the bowel. And
I don't know.
also
You can explain it both. You can explain it both way. I think, to say the least, the results are surprising to me. It would be good to have a conversation with Gernot. Maybe we'll bring him back as a featured presenter, and because this is really an interesting discussion point. It goes against what we always thought, that the less is more. You know, if you can get something out with a disc, you get it out with a disc. And certainly we're not going to, you know, they're not suggesting, or I don't know, we are not going to now do a segmental when a disc is doable. You know, that just goes against the surgical principle of the least invasive necessary thing. Okay.
But logically, if you're going to cause any sort of subtle nerve damage from a sort of autonomic dysfunction, you can't argue that you would damage less nerves with a segmental compared to a disc.
Yeah, you can't argue that at all.
I think it's difficult to comment, because I think like the numbers of disc in this paper is too little.
I think that probably is the anomaly. Yeah, Tom, you want to say something?
Yeah, no, I was just saying the numbers are the key thing, and I think that at small numbers you may not see the difference. The other thing is, you know, whether you're doing a disc, whether looking at those specific ones, the size of the lesions, complete excision, or, you know, and I think more details about surgical technique and are really important as well. And similarity and all of those things.
Well, the only other explanation that comes to my mind is that, is it possible that with a disc there is remnant disease, and these are cases where had multiple nodules that weren't removed? Maybe, but Gernot is a very skilled surgeon, and you know, I know that wouldn't apply to him. Okay, thank you.
Okay. Rakesh, are you there to present your one?
Hi, yeah, I'm ready. Can you see me?
Yes, we can, Rakesh.
Hi. Good evening, everyone. My name is Rakesh Singh. I'm one of the senior trainees in King's College Sussex Veterinary in the UK. Today, I'll be presenting a systematic review on meta-analysis that compares pregnancy outcomes after colorectal resection versus other surgical procedures, namely shaving, and disc excision in women with deep infiltrating rectal endometriosis. This paper aims to shed light on a long-standing debate regarding the impact of surgical choice on fertility outcomes. And the aim of this study was to compare pregnancy outcomes after colorectal resection versus other surgical techniques like shaving or disc excision in women with deep rectal endometriosis. A total of 13 studies involving 3,248 women were included in this systematic review and meta-analysis. As shown in the PRISMA flow diagram on the right, over 4,600 records were initially identified, but only studies reported pregnancy outcomes and relevant surgical techniques were included, resulting in just 13 eligible studies. And the meta-analysis and systematic review included 13 studies, mostly from Europe, with a mix of prospective, retrospective, and randomized trials. Pregnancy data were available for over 2,100 patients, most of whom had colorectal resection, that is a lower anterior section, followed by shaving, disc excision, or expectant management. Surgical approaches varied. 5 studies were fully laparoscopic, 2 were laparotomies, and others included conversions. In terms of results, for spontaneous pregnancy, there was no significant difference between colorectal resection and other techniques. However, overall pregnancy rates were significantly lower with colorectal resection, 35.5% versus 42.6%. Compared to shaving, resection had a markedly lower pregnancy rate, but when compared to disc excision, the difference was not statistically significant. So some takeaways. In summary, colorectal resection for rectal deep infiltrating endometriosis is linked to lower pregnancy rates, particularly when compared to rectal shaving. While it may reduce recurrence, it appears to compromise fertility, suggesting a need for more conservative options when fertility is a key priority. Management should be individualized, ideally with a multidisciplinary setting based on disease severity and reproductive goals. However, the conclusions are limited by low-quality evidence, surgical heterogeneity, and inconsistent reporting across studies. So we need big randomized trials for this finding, because this is the first ever study done comparing colorectal resection and pregnancy outcome. Thank you very much.
Thank you, Rakesh, for the presentation. Yeah, I think. What do you think, Mr. Casale, about this study? I think.
I think it just highlights something really important in surgical research, and that is the assumption of causality is the difficulty. You know, it's not the segmental resection that is associated with lower pregnancy rate. It's the fact that the patients who underwent segmental resection almost certainly had much more severe disease. You know, it's a bit like saying, I don't know, to bring an example from cancer, let's say very early stage breast cancer, the treatment is mastectomy or nodulectomy, and very high stage breast cancer needs chemotherapy. And then if I did an RCT and found that patients who had chemotherapy have a lower life expectancy, it's not the chemotherapy that killed them. It's the fact that they had higher stage disease that needed chemotherapy. So, although the devil's in the detail, I think perhaps, you know, one should have a look and find out if they took that into account or not. But on its face value, I can't see the logic of how the procedure itself could be the only factor that could affect it.
Yeah, exactly.
They
I think
have
we can move on with our feature article now. Thank you so much for joining us. We have today Mr. Tom Smith-Walker, that is a consultant gynecologist and endometriosis lead at the Royal Cornwall Hospital. And today he's gonna introduce to us the new updated NICE guideline for endometriosis, the diagnosis and the management. Thank you for joining us.
Tom, thank you very much. Just wanted to add that me and Tom go back to BSG Council days. You know, like Flo and Ben, who are now on the council, and colleagues.
Well,
And Tom, we're both, I think we were both trainee reps, or we were after that.
You would just complete. I think you would just finish. I think I followed on from you on the trainee rep.
Okay. Yeah,
and
that goes back to what, 2009, 2010, something like that.
Yeah, around about then. We go back a long way.
Yeah. Okay. Well, thank you very much for accepting our invitation, Tom.
That's okay. Thank you very much for inviting me. It's a real privilege. I will share my slide if that's all right. If I can. And so, excuse me while I do that. Okay, can you see that? Is that okay?
Yeah, that's great. Thank you.
Brilliant. So yeah, no, thank you very much for inviting me. So I've just was involved recently or last year with the update of the NICE guideline for the diagnosis and management of endometriosis. It was a really interesting experience, and I'll go through that. But my name's Tom, and I am a consultant down in Truro. We've been an endometriosis centre since 2009, and so, you know, we've got a reasonable amount of experience with endometriosis. And so when the opportunity came up to have an influence on the guideline and go through it, then I was really excited to take the opportunity. If you've not had the chance to look at it, it's guidance number 73, and it was first published back in 2017. And it was the first real sort of nice guidance specifically on endometriosis, and gave a really good outline on the management of endometriosis from primary care all the way through into secondary care, and about the initial sort of diagnosis, getting patients seen, and trying to streamline the service for these patients who previously had sort of gone around the houses with a delayed diagnosis. And I think things are improving and speeding up. But you know, the process of being on the NICE committee, for those of you that haven't been on it or involved in it, it is a great experience. And for those that get the offer or are keen or interested in joining it, then keep an eye out on their website for people to join the various different committees that are there. But just as a sort of an idea how this one came about, when there is new research or new papers or publications that are out there that might influence the guideline, these are highlighted, it's taken to the NICE committee, and they decide whether it's relevant to review the guideline. And then if they think so, then they will then form a committee to review the evidence and then see and update the guidelines accordingly. So this all started back in March 23. And for a committee, there's the chair, who's not necessarily clinical or topic related. You get a topic expert, and that was my role. There are several other professionals that are involved in it. So we had Christian Becker, Lucky Saraswat from the consultant body. Then we had Claudia Tai from the endometriosis nurse specialist. We had Bryony Gordon from general practice, and we had some trainees as well that were involved. Then you have a group of patients or people with lived experience of endometriosis, and that had a really valuable perspective. Stakeholders, we had Emma Cox from Endometriosis UK, and then you have the NICE research team from the paper analysis, statistical analysis, financial analysis, and who are essential to the whole process. So it's a large team that pulled together to review these areas. It's done over Zoom. And so again, all of us were all from different parts of the country, so it involved a wide It becomes very inclusive, which is great. We then review the evidence, discuss it, debate it, put the proposals forward, send it out to the stakeholders. So some of you may well have been on the stakeholder review and would have had the first draft and then a chance to do that. We then consolidate the information, and then the recommendations are published and then released. So that's just an overview of how to do it. And as I say, it was a really interesting, rewarding experience, and do get involved if you get the opportunity. So the topics that came up that we were asked to look at. So that was the only thing that slightly that took me, that I was surprised about, is that when you're asked to review a guideline, you think you're going to look at the whole guideline, you're going to look at all the areas that might change. And so we all reviewed the guideline in its entirety and had sort of wider ideas. But actually, it was these three parts that were particularly picked out. So the three key parts that we were looking at, and our role wasn't to look at the rest of the guidance. What was really acknowledged was that there's probably some more changes to be done. And we've put that back to NICE, and hopefully that will lead to some more changes going forward. But the ones we were looked at where fertility was a priority were hormonal treatments, surgical treatments, or a combination of therapy beneficial to improve spontaneous birth rates, conception rates. So that was looking at patients with endometriosis, recurrent symptoms, or if they are asymptomatic, diagnosed with endo. The other one was then looking at the cost effectiveness and clinical benefits of, in the management and diagnosis of endometriosis, of imaging, biomarkers, surgical diagnosis, and that's either open or laparoscopic surgery. We focused on those two. The third topic was about post-operative analgesia following surgery for endometriosis, and the general consensus was that this post-operative pain relief is a wider topic. Looking at more specific for endometriosis, then we thought that it would be really difficult to pull together that evidence from what was there. So we have deferred that through to further review about general post-operative analgesia from that side, and for another time rather than focusing for this guideline. And there was also there was a general evaluation of the initial diagnosis and management as well, but overall we have recommended that the guideline is completely reviewed to bring it up to date with current standards and practice. And then the guideline is published, and the BMJ released their summary as well. So there's a good summary article in the BMJ that came out in January this year. There's a good patient decision tool, or there's a good tool for primary care, a flow diagram that is worth looking at, that highlights where the changes are and allows a nice sort of easy flow. And I'll put it up at the end if we have time. So what were the changes that we made? So we looked at the first bit, which is sort of more referring to in primary care, and we looked at the initial history and assessment. And one of the things that came up more frequently is about being inquisitive about potential other risk factors for endometriosis. And one of the things that came up time and time again is about people with a first-degree relative, whether it be mother or sister, and there being a common familial element to it. So again, it's just to add more signposting for the GP to think, is this much more likely to be endometriosis, particularly where a first-degree relative has it? And so that was one of the first things that came out. The other thing that came out from a parliamentary review, all parliamentary review in 2018, about different people's experience of pain and symptoms related particularly with endometriosis, and looked at patients with neurodiversity and how they might express pain differently, might find it difficult to locate and express more specifically around their pain symptoms. But so important to take that into account, but also take into account the needs of that individual, whether you need to involve family members, carers, or the learning disability team, or the neurodiversity team, in order to help them to get their symptoms across in order to help make the diagnosis. And I think certainly, I don't know how others would feel about it, but I'm seeing more and more patients with neurodiversity coming through the service who have found it difficult, and it's taken a long time to get to the endometriosis service because of the hurdles that some of them can face. And then importantly, about signposting, if they are suspecting endometriosis, then to give the information early on, to signpost to reliable sources of information. The Royal College and the BSGE, Endometriosis UK all have very good patient information that is consistent and reliable. And so preparing people what to expect when they go through to an endometriosis service. And also making them aware of their treatment options early so they can think about it before they come and see us in the clinic. We also talked about examination and about the importance of doing a complete assessment, again, in primary care, and as much to diagnose, but also to exclude other causes for patient symptoms. So always offer an abdominal examination, but also to look at a pelvic examination as well, because this might reveal signs and symptoms that would direct you straight to an endometriosis service potentially, or would direct you through to diagnosing a larger pelvic mass that might actually be causing their symptoms rather than endometriosis. So, and if people decline an internal examination, still offer them an abdominal examination. You might again feel a pelvic mass that would be there. But also, if they're declining internal examinations, it might give you an idea as to what to offer them when it comes to imaging. If you are looking at ultrasound, that they may inquire about whether they would have an internal ultrasound scan. And if not, then still offer them an abdominal imaging. But we'll talk about imaging in a minute. So it's just trying to set the standards for care in primary care to make sure that they are covering all bases when it comes to getting the diagnosis. These are obviously small parts of the rest of the recommendations, so piece them in with the other parts of the guidance. The other thing is to get the GPs, or primary care folk to refer early. Don't delay. Don't wait. If you have a strong sensation that this is endometriosis and the patient wants further assessment and investigation, make the referral through to the service, but also book the ultrasound scan at the same time. And there's no reason why you can't initiate medical therapy, whether it be analgesics or hormonal treatment. So don't delay treatment, but don't delay referral as well. We're encouraging, or we would say that the GPs or primary care should arrange the ultrasound scan in the first instance. And the reason that we're saying this is because that you may identify alternative causes for pain. You might identify alternative causes for the symptoms that they have, whether it be fibroids or a simple ovarian cyst. But also you might pick up endometriomas, and the guidance, and again we'll talk about it in a minute, would be if you see an endometrioma, then that should trigger a referral through to the endometriosis service so that they can access specialist care early. Because we know that if endometriomas are seen, or there's a suggestion of deep endometriosis or extraperitoneal disease, then or extrapelvic disease, then they should be seen by an endometriosis center. The other thing we said is that under 17 ideally should be referred to a specialist pediatric gynecology department rather than the general gynecology department. And most, I think all units have access to this service, or through to an endometriosis service as well. So the main two topics that we looked at were imaging, so looking at diagnostic imaging modalities. If you go to the guidance, there's a drop-down paper that will give you all of the references, the analysis of the papers the new papers that were brought to light, and the rationale around the assessment. But there were 29 new studies that were picked out from across the globe, looking at different imaging modalities, looking at ultrasound scans, looking at MRI scans, and looking at the accuracy of diagnosis of deep disease. And what it did show, and I think that unsurprising, is that that there is benefit in imaging with specialist ultrasound scan and MRI scans in diagnosing deep disease. And so therefore, that's where it comes into specialist ultrasound, specialist imaging that's set up by appropriate people doing the right investigation. Ultrasound in the right hand is incredibly sensitive for diagnosing this deep disease, but in the general radiology world, I'd say that it is very accurate at picking up endometriomas, but not so for the deep uterosacral disease or rectovaginal disease. MRI scans equally are very good at picking up deep endometriosis and assessing the extent of the disease. However, the images need to be interpreted by someone who is familiar with looking at gynecological endometriosis MRIs and making sure that the settings are appropriate to an endometriosis protocol. Different settings will have different sensitivities of identifying the disease, and that's absolutely key. And I think that's why it's really important that that the people requesting the specialized scans have links in with the radiologists that do these procedures. Because of their ability to diagnose and plan, identify deep disease in the right hands of these modalities, then again, you can consider performing these investigations before any laparoscopy or any diagnostic surgery, again, to help plan definitive treatment. And the sort of takeaway message is a negative ultrasound, although in the right hands they're very good, a negative result doesn't always exclude deep disease. And therefore, if you are still considering endometriosis, then you can move forward to laparoscopy in order to diagnose. When it comes to the actual surgery itself, it's just highlighting the fact that the surgery should be done with some of the appropriate skills and knowledge of endometriosis. And I think it sounds like it's common sense, it sounds logical, but a laparoscopy done in the wrong hands is something that can be really negative to the patient. So a misdiagnosis of endometriosis can set a patient back a long way. So I think it is absolutely crucial that it's done by someone who has a knowledge of endometriosis, that is able to perform a systematic pelvic assessment. So looking at all the areas that are required of the pelvis, but also the common areas of extra pelvic endometriosis. And then when you are recording this, it's documented clearly what the normal findings are and the abnormal findings, and that the appropriate pictures are taken. So most people will use photographs, taking on the stack, but equally video is a really useful tool, but the challenges that we have are storing imaging. But there are lots of ways around that. But the images will give you clear images will give you a full story of what the degree of the disease is, and plan the surgery going forward. Again, treat endometriosis laparoscopically. There's no reason to proceed to an open procedure unless there's any specific contraindications for that patient to have a laparoscopy. And the other bit that again was highlighted as being important and flagged up from clinicians, but also from the people with lived experience, was if a laparoscopy is negative, and even if it's positive, make sure the patients have had that discussion with you. It's often patients will leave without having had a discussion. They're just told they've been discharged. And this was certainly the experience that came back from the feedback, that people want to know what the results were. And if it is negative, then a direction, a suggestion of what the next steps might be for them, even if it is refer back to the GP to consider alternative management. But it's being clear about where your relationship with that patient is ending and starting, and the findings from that surgery. So biomarkers was something that we just looked at as well. I think biomarkers is a growing area, but what we generally saw was the evidence was small, with small numbers, without good data, with quite high costs associated with some of them, and the sensitivity and specificity was not there to say that this is something that should be used as a routine diagnostic tool. I think that things are still in the early phases of development, and I think this is an area that will grow. And I think as more evidence comes to light with larger numbers, with more again with the cost effectiveness as well, then this is something that we will probably see more in routine practice. But at this stage, the evidence was not there to support the introduction of any routine biomarker testing. The areas that we looked at from fertility, where fertility is a priority, there were 12 new papers that had come up. And again, the link is there in the paper. And the two areas specifically that were looked at were about how we manage endometriomas. And I think this is something that's quite topical at the moment. I suddenly saw Shaheen's video, I think, recently on some treatments of endometriomas with sclerotherapy with alcohol. And what is clear is where there is concern over fertility and where there is potential compromise to ovarian function, then drainage and ablation, and it looked at vaporization and sclerotherapy, so different techniques for it, but it showed that there was less damage to the ovarian function and the ovarian reserve. So this is part of the discussion that came in, that why would you refer all of your endometriomas, patients with endometriomas, to an endometriosis service? And part of it is because the endometriosis has access to a multidisciplinary team, which will include fertility, to make sure that patients are fully counseled and appropriately had the discussion about fertility, where it's a priority, what are the techniques that are being employed, what are people doing in order to manage it, and it's to make sure the patient has the right and the best treatment that's appropriate to their scenario, to their, their ovarian function and their desires. So that was, I thought it was a really useful and interesting bit of research and recommendation. The other one was to look at hormonal treatment prior to surgery, in combination with surgery, and hormonal treatment alone. And there were mixed results from this. The difficulty that we had looking at these new bits of evidence were there was no consistency. So some were using progestogen, some were using GnRH analogs, some were using herbal treatments, and some of them were giving, and there were different durations, pre-surgery, post-surgery. So the evidence just wasn't consistent, and it sort of gave a mixed picture. Overall, on balance, it felt that there was no significant increase in the spontaneous conception rates from combination treatments with hormonal and surgical over surgery alone. And therefore, we couldn't recommend looking at giving hormonal treatment in combination with surgery to improve spontaneous fertility rates. I think it's definitely an area of research. And I think that if there was more consistency with regimes and doses and medications, then I think there's certainly something that could be gained. So what we have done is recommended it as a further research point. So that's just a summary of really of all of the main areas that we looked at from the NICE guidance. You can link in to obviously to NICE itself and the BMJ articles that give the decision aid, the flow diagram that's there. So by all means, take a chance to look through it. But that was it in a nutshell.
Thank you so much, Tom, for this presentation. Beautiful presentation and really nice guideline. I think we have done some really big step forward with this guideline. There are a couple of questions. Let me read them to you. So Marco Zaccaria is asking, dear Dr. Tom Smith-Walker, regarding the type of endometriosis, which kind of classification methods would you mostly recommend? Like, did you base it on the Enzian? Did you base it on the reproductive medical system? Which one did you base it on?
So each one used everyone used different staging systems when it comes to the scoring of the staging of the endometriosis. So again, there's a lack of consistency over staging when it comes to these. So someone says they did remove the endometriosis, they describe it as deep endometriosis, but they haven't necessarily staged it in all of the papers. But most of them will use the American fertility scoring system. So they're not using Enzian.
I think we're moving more towards the Enzian, though, especially here in Europe.
I think that's what we are moving across to, isn't it?
Yeah.
So that's what we will do. And again, it's about consistency, isn't it, over these parts, because it allows comparison of like with like.
Yeah, exactly. We're talking the same language. Then someone anonymous here is asking, if you suspect endometriosis, we're talking more about we're suspecting endometriosis, we're thinking about doing surgery. So when a laparoscopy is planned for possible see and treat, is it better to be done in an endometriosis center? Most DGH surgeons have minimal training in endometriosis laparoscopy. So what do you advise in these cases? And I think it's difficult to answer, isn't it, Tom? Because in some DGH, there are some really, really strong surgeons. It's difficult, isn't it?
I think it's really tricky. I think definitely where there's a definite diagnosis of deep endometriosis, then it needs to be done within a center. I think the idea of a center doing all diagnostic laparoscopies is unrealistic. I just think that, however many laparoscopies are done a year in a DGH, if that was done by the 2, 3, 4 surgeons in a center, then that's I think it's unrealistic. I think what our role is to help support the DGHs and educate, and where there is that sort of ability to develop a relationship where we can review laparoscopic images, videos, and just sort of check in with them, and when they have questions and concerns, is work with them. I think that the other thing I know that what people find really beneficial is operating with other people, and I think invite your surrounding colleagues to come to your theatre and see what help them with updating their training and their learning. So that's work with the DGHs, but we don't do all the work for them.
Yeah, I absolutely agree. Actually, you got spot to the points like perfectly. Yeah, I mean, I think it's like you said, it's realistic. If we do every surgery in the endometriosis centers, it should be only dedicated for this very severe colorectal disease, or when the blood is very involved, the ureters are involved. But in DGHs, there are really some strong surgeons that can deal very well with the moderate disease.
But I think there is a probity to individuals, and I think that there is that side of it and it's very difficult for people to accept that they may not be the right person to do the surgery. There are certainly some people who still do a laparoscopy and they just have a look. There's no movement of the bowel. There's no exposure of the pelvic sidewalls, no manipulation of the uterus. And so you're never going to see disease that they don't take the fluid out of the patch of Douglas. And, and the moment, until you do that, you'll never get a full appreciation. And that's why I think it's, the guidance is, and that's why we try to get it there, is that the images should reflect the assessment of the pelvis. If you've not got the evidence that they were looked at, then, and that's where the images I think are more powerful than the words, because then you can see that the bowel has been moved, you can see the fluid's been removed, you can see the ovaries have been lifted. And, I think I do strongly believe that that's what's missing from, if you don't have that evidence, you can't be certain that the appropriate review's been done.
Do you think we should standardize then the way we took images and say that every pelvic pain patient should have one image of a nexa, one image of a pelvic side wall before and after uterosacral, so you have a total number of images that cannot miss from the documentation? Is it maybe asking too much?
No, I think it's, well, I did do a brief, with one of our fellows, we did we were looking at a study that looked into it. And I think there were 9 set photographs, 9 pictures that you could do that took about a minute and a half to do all of them. And so, they were fairly standard. It was a global picture. It was left adenexa, right adenexa, side walls, uterovesical fold, pouch of Douglas, with and a view of the uterosacrals and the pararectals, appendix, diaphragm, both sides. And so that was just that, and that kind of covered most of the bases. Or you could do a video, which again took about a minute to do those surveys and show it clearly. And it really isn't a highly technical skill. It's just being disciplined. You know, if you ask a sonographer to do a pelvic scan, they scan in a systematic way.
Yeah.
There's no reason why the same. So I believe that we should have a set number of pictures that are done for a laparoscopy.
Hopefully we can introduce it in the guideline when it's going to be revised. This is a recommendation.
Yeah, the thing with writing guidelines, you know, having been on some of these or similar ones, you know, I had an experience with ESHRE and also RCOG. It really is reliant on level 1 evidence. And again, the problem is when it comes to surgery, we either don't have good level 1 evidence or the quality is extremely low. And sometimes, actually, historically, I think we've seen more damage than benefit, harm than benefit from the fact that we only look at level 1 evidence. You know, hysterectomy was a very good example of that. That NICE guideline for many years was recommending that we don't do a laparoscopic hysterectomy. And I think this NICE guideline, again, that's not a criticism to you, it's just the way NICE works, that we're still saying excision or ablation. We're still saying, because we don't have an RCT, and everybody knows, including from very large studies coming from the UK and other places, that excision is the way to go. NICE still says excision or ablation. But what was surprising to me, and I think it has been corrected in this version, was that even though everything needs to have level 1 evidence to go into NICE guideline, somehow still that doing 2-stage operations and putting people on Zoladex for 3 months did manage to find its way to the previous guideline. I can't be sure if it's still in this guideline or not. I couldn't see it.
It wasn't taken out. It wasn't an area that was looked at. But I think, I mean, I know where it came from.
I can guess where it came from. Yes. But it's interesting because, you know, not only it doesn't have level 1 evidence, it doesn't even have level 4 evidence behind it. But opinion of people have managed to. And so that my question to you is exactly that, you know, how much does the opinion of people on the panel count? Or is it that, you know, it really needs to be based on good quality evidence? How does it work in real life?
I think it depends what you're trying to change and challenge. And I think that, you know, the specific topics that we looked at, so that when it comes to the fertility and it comes down to and the other investigations, then that becomes less debatable. You know, the evidence is presented, and I think that's fairly, you know, personal opinion doesn't necessarily come into it. I think there are a few softer areas where evidence isn't necessarily there. So talking about the assessment examination that you want in primary care, talking about, you know, being mindful of first degree relatives, things like that isn't necessarily got the full evidence base, but there is, there triggers that are common sense to help primary care to start to be more suspected and also be aware of their patients that are coming through. And some of those things you may, so I think there is more influence that's able to be had. I think it's really important to, and this is where I think all of us found it difficult when you look at the whole guideline, because there are some things that we do disagree, you know, that we will have some disagreement on. And I think that, you know, the ablation versus excision is a really good one to look at. And that's a really tricky thing to unpick and take out with just discussion, because it's such a big change over approach, because that does change things fundamentally for quite a few surgeons that are doing things. that without the evidence, it's difficult to change.
It would be, I don't know what the solution is, but that's an example of how to demonstrate the problem, that you and me know that, you know, a lot of the patients suffering and prolongation of their suffering and repeated surgery comes from that ablation wording. But you can't take it out from the NICE guidelines because there's no level 1 evidence. I wouldn't expect NICE to do that, but that just demonstrates the problem, that, you know, we know that's the problem. But yeah,
I think the way round, and I think this is how you try not to influence things with your personal biases, and I think that's really important, because I have certainly seen a lot of guidelines that have been influenced by personal bias. And when you read the guidelines, you go, oh, I know who wrote that. And that's really clear, and that's there. But the bit I do feel strongly about, is the person doing the laparoscopy has to have the appropriate skills and ability. And I think that overcomes things like the ablation excision argument. You know, things like that, with the person with the right who keeps up to date with the education, with the training, then hopefully they are then treating it with the current education and research. And having that evidence to support them, you know, and making sure that the evidence is recorded through imaging and, you know, whichever modality you use, then has that quality control level that can be, you know, if you ever needed sort of a question and assess, then you've got the evidence that's there. And so that was my thought behind those parts of it.
Yeah. In any case, I think, you know, since the NICE guidelines came out and the review and the update that you've been involved in, it has done a lot of good for making sure that the primary care physicians, that the GPs are really referring these patients on. There is some structure. And there is some recommendation, particularly the simple ones. Sometimes the main impact comes from a very simple recommendation that, you know, for example, if imaging is negative, that doesn't mean you don't have endometriosis. That simple sentence can actually change lives. So it's wrong to expect everything to be fixed at the same time. But it's a difficult one, I think. Anyway, thank you very much, Tom. We're coming to an end, actually. It's 6 o'clock. I'm very sorry, Flo and Rakesh. I don't think we have time for your thing. It was such an interesting discussion. And no, it's really good to discuss these things, and your presentation was really helpful as well. And I'm sorry I was late, but Ben, very grateful to Ben to chair it, and thank you, Flo and Rakesh. That's your inaugural session. I'm sorry that you only had time for one paper. And Tom, please tell people about LEJEndo. We have been running this every month for now, what, 2.5 years? And it's always on the 6th of every month at 6 p.m. And usually it falls on a day where I need to go pick my daughter up or do something like that. I'm sometimes late. But anyway, Ben, do you want to close?
You have done it already amazingly. Like, thank you very much, really, for joining. And yeah, it was a perfect paper, this one, and debate. We could have carried on for another 2 hours or 3 hours talking about this, probably. So maybe we're going to re-invite Tom again. Thank you very much for joining us, and see you in a month's time.